Give me just a second. I'm going to set up here. Just bear with me. There we go. All right. Let's see if I can. All right. Let's see if I can. All right, testing. All right, testing. There we go. Let's turn this sound off. Good. So that way we don't get an echo. All right. Hi, everyone. Hopefully you guys have had a good, absolute Monday. And this is number 2 of the education piece. So we're going to talk about why therapists do what they do. And in this episode, we talked about, in the recorded episode, we talked about shoulder impingement. Hopefully you guys will go back and look at that one. I'm quite proud of that. I worked a little bit into that, and we'll see how you guys like it. So what I want to do tonight is really talk about the research behind shoulder impingements. And so it's not just my crazy ideas, but it's actually happening. And where is that information coming from? Is it coming out of just the top of your head, average Joe, or is where are you getting your information from? And so let's go ahead. We're going to go ahead. So this research article is from a Christine Gaving, Isabel Bauer. And this research article was back in 2017, so it's a fairly new one. It's in the last 5 years, so that's good. And what they looked at here is the learning objective of this article is understand the causes of shoulder impingement, which is very important. Identify the affected patients in order of the appropriate diagnostic testing for them. So what type of testing do we have to do to try and figure out the impingement in the first place? And then know what forms of treatment are suitable. So this research article is really going to look into, and this is from the Journal of Medicine. And so they really looked at that. So the summary of the background was shoulder pain is the 3rd most common musculoskeletal complaint in orthopedic practice. I think it's number 1, but you can never tell. Like I said in my video, it's usually either osteoarthritis, it's usually either some sort of rotator cuff tendonitis, or possibly the shoulder impingement. Hi, Kimmy. Hi, nice to meet you. So what I'm talking about here tonight is shoulder impingement, and really from my video I just dropped last night or yesterday afternoon, this is kind of tailing into that. So really what we're looking at here is, hey, you came out with that treatment, you came out with all that information, where did you get this stuff from? So I'm getting it from 25 some years of practice, as well as all the current research data that says, yeah, if you do these particular things with your shoulder problem, you're gonna get better for it. So they looked at the specific etiology of basically what was the cause of the impingement in the first place. So like, okay, was it a fall? Were you sleeping? What was the real reason why this person had a shoulder problem in the first place? And like I said, it's usually tendonitis, it's usually some sort of arthritis, or in this case, the impingement where the tendon gets pinched and swells up and then causes all these other problems. So in this, they basically looked at and said, okay, there's some other issues why you might have impingement. Number 1, you might have some bony narrowing. And what that basically is if we looked at on this bone, what I talked about in that last video is this. This is the acromion, and this is the back here. I didn't go into a lot of detail, but this is actually called the spine of the scapula. So scapula being the shoulder blade, and at the tip here is your acromion. And I talked about that tendon sitting underneath, and what can happen here is, let me get a little demonstration here. Look at this pencil here from the side. If this bone hooks over more and grows over more, it's much easier to cause that impingement to occur, and that's what happens. And there's actually 4 grades. It's called the hook of the acromion, and literally as we age or as we put a lot of stress on this bone area here, this acromion, it actually starts to grow a hook on the end of it. And you can clearly see it on an x-ray, but that hook literally will dig into the muscle as you raise your arm over your head, and you can just imagine something digging into that tendon and then causing it to fray, causing it to tear. So a lot of times this could be an abnormality where you're kind of partially born with maybe a grade 2, where it's a little bit thicker and a little bit further out than on most people, because we're not cookie cut. Because we're not cookie cut here. So the reality is because we're not cookie cut, what I mean by that is you could, like I said, you could be born with that stage 2, and then as you get older and through stress and through work or falling or an injury, it turns into a grade stage 3 or 4 much faster than it would have someone that was never born with the problem in the first place. I talk about that a little bit in the spine, and probably when I go down the lower back spine area and the research into that, I'll probably spend a lot of time in that area, because that is actually the most expensive issue going on in the medical community right now. It's not the common cold, it's not cancer, it's actually low back pain. It costs billions of dollars each year to treat low back pain, whether it's surgical, whether it's medicine, diagnostic testing, but that's for another time. But in this particular one, so that's how easy it is to hook that. So this research article took that into consideration. Hey, some of these people have bony abnormalities, and that being one of them. The next thing is fractures. So they looked at, okay, what happens if maybe you fall and you fractured it early in your life, and then it healed, and then later in your life you started having some issues with your shoulder, and you thought maybe it was related to just arthritis, and the reality is it's not. You had that growth that occurred. And see on this page, it actually talks about the different stages of the acromion and how it can actually get larger as you age, and whether it's through fall and arthritis, or whether it's just through, maybe like I said earlier, we were kind of born that way partially. So you were more susceptible to that problem. So right here they talk about advanced subacromial impingement syndrome. So that's what they talk about. They kind of give it a name. So they did an exhaustive physical on all these patients, and they really came to some nice conclusions. So we'll go over those in just a little bit. So they did some ultrasounds, they did some x-rays, they did some fancy measurings to the shoulder to really figure out, okay, let's get some groundwork to see if just because it happened to one person, did it happen to someone else? So what they did is they also did a bunch of what we call orthopedic tests. Now, if you go to your doctor or primary care, PCP, your physician assistant, nurse practitioner, or your physical therapist, they're going to do a bunch of different orthopedic tests to truly see if it's osteoarthritis, excuse me, if it's a tendonitis, or if we're dealing with some sort of shoulder impingement. And so there's a couple fairly tests that they do. They do what's called the painful arc, and I talked about that, where you kind of hurts throughout the whole range. That can be classification. Near sign, where they kind of come up and they rotate your arm in to see if it kind of pinches there. They do what's called the Hawkins impingement test or sign. They do that. And if you get 3 or 4 of those tests that are come positive, hence they're going to diagnose you with shoulder impingement. And they're going to treat you like I've shown you over the last several videos, as well as the one I just dropped yesterday. So hopefully you guys like this stuff. Hopefully it's not too dry to you, but it kind of does give you an idea why we're doing it and the reason why we're doing it. So the next one we want to do is look at what's the conservative treatment. What did they do for this shoulder impingement? And they did several things. They did a mobilization, which is they rested, which I talked about that, what you want to do. They did NSAIDs, non-steroidal anti-inflammatory. So they did the ibuprofen, the Aleve, the naproxen. They did those medicines. And then they did a cortisone injection. So that's what the doctors did. They did those three things. And so two of those three things you can do at home. They didn't ice it, which they should have. But two of those three things you don't even need to go to see a doctor for. So, and then they did physical therapy. So they went and did a physical therapy, did treatment. In the physical therapy, they did ultrasound. And I've talked about that way in the past. So really what they're going to do with this is they're actually going to use ultrasound as a thermal treatment. So they're going to use ultrasound to kind of heat up the tissue around the area to try and get that inflammation process going again to start the healing process. So I talked about that in the difference between tendonitis, peritendinitis, and tendinosis. So when you're at a tendinosis stage, that means the body's way of healing it is gone past the whole inflammatory process. So now you're dealing with something that's chronic and it's not going to heal. So they did that. They did some manual therapy, which I talked about that in my last research article, where manual therapy and exercise, did it really work? Not really. And then they did therapeutic taping, okay, and then they finished up with some acupuncture. So those were the various conservative treatments that they did for the therapy. So with the cortisone injection, they did subacromial space of the glenohumeral joint. So they went in here and did underneath, right where my finger's at. Okay, you have the acromion and then the subacromial, which is basically that space right where my finger's at and where that tendon comes out at. And that's why it impinges there, which I talked about in my research on my, I always want to say research. I'm mixing up the words here, people. You forgive me. Looking in, when I did the recording, I talked about where it pinches at. And that's classically right where they're going to inject it. They're going to go right from the back side of you and come in underneath, and they're going to give it a shot right there. That's the subacromial space. So what they did here is the patient was given simple exercises to carry out independently several times a day for several weeks. So they did several things. One of them was avoiding mechanisms of repetitive injury. So you want to stop doing the repetitive trauma that started the problem in the first place. Achieving free joint mobility. So they want to work on those exercises I talked about early on, which is the pendulum exercises, so you keep your motion. Strengthening of the shoulder. Once the shoulder has regained full mobility, the next objective is to build up muscle strength. So they did exactly what I've been talking about in all my videos. Conditioning through endurance. So they did some endurance-based exercises. And then adapting work and sports activities so you don't re-injure it again. Sometimes that's not so easy. The job is a job no matter what. So this piece they did what's called a subacromial decompression. So they literally went in there, they rotor-rooted it out and cleaned this. And if there was a hook on the end of it, they also shaved that piece off too. That way you really opened up the space for the shoulder. So when they looked at part of this research, when they looked at what were the predictive factors of improvement or not improvement, it was based on was there any type of partial tear or full thickness tear of that tendon. So if there was a full thickness tear, the recovery was poor with those particular treatments. And we looked on that in the meta-analysis in the last article, which basically said the same thing, is that you could do exercise and manual techniques and some exercise. If you have a full thickness tear, you're going to improve your function and the patient's overall perception of pain, but your range of motion isn't going to make significant improvement. And this research article that was done a year later, because that meta-analysis research article I talked about last visit was done on 2016. This was done on 2017, so this was published a year later, so it wasn't even in that old meta-analysis. So that meta-analysis, which had over 3,000 participants in it overall, really shows exactly the same thing, is that, yes, if you have a partial or full thickness tear of your shoulder, physical therapy is going to reduce the pain and improve your perception, your thoughts of it, you got improvement, but overall your range of motion isn't going to improve. So when I talk about osteoarthritis, tendonitis, or impingement, that has absolutely nothing to do with what's going on here. They're talking about a partial or a full thickness tear, which means is the darn thing is that supraspinatus tendon, that muscle that sits right inside this groove here, which is one of the four. You have your supraspinatus, which is the top one. You have your infraspinatus that literally sits in this spot. You have your subscapularis that sits on the inside of your body. Okay, so if I come over here to the spine, it literally sits, that muscle sits on the inside where your ribs are at. That's your subscapularis. And then your teres minor sits on the other side of it. Kind of sits over in this area underneath your armpit. And they all attach to the shoulder, and they rotate your shoulder out and in. So that is the case with that particular research article. Now, they had several different questions here for the participants. And one of them was this. In a patient with confirmed shoulder impingement syndrome, on a plain x-ray and an MRI of an affected shoulder obtained, what findings is not typical of an impingement? So they had here several different answers. They had high humeral head position, which means is the head of the humerus, this ball right here, is much higher up towards the acromion. So the space is much smaller because you were kind of born that way. So it automatically gives you a predisposition to the impingement of that tendon. So, you could be as strong as an ox. The reality is if you're kind of born with some of these, we're not calling them defects, but they do tend themselves to problems as we age. Or the hook on the acromion, we talked about that. And then we talked about the tendon indentation or an abnormality of that hook to begin with, or complete rupture of the supraspinatus tendon and the tendon retraction. So what that means is that tendon, that muscle sits underneath here where my finger's at. Let's see if I can get a good view for you folks. Sits in here and comes underneath and comes out the other side. Now what happens, that tendon's attached here. If that snaps off, that literally, like a rubber band, recoils back, and that muscle is kind of just sitting there sagged, all bunched up with that tendon in there. And the doctor really has a very short period of time to get in there and fix that and pull it back. Because that tendon, it can't just stretch back. What happens is, unfortunately, that tendon starts to lose its flexibility or its stretching ability the longer that it stays in a shortened position. Literally at the cellular level, it starts to lose what we call sarcomeres. And so what I mean by that, there's just these little things in there that tell that tissue to lengthen, okay, and to shorten. And your body, they start to go away, and next thing you know, you do not have that ability anymore. And so at one point, it's like, yeah, we don't have that. Now, it happens a lot in the bicep. You might see it, they call it the Popeye arm. If someone literally, there's obviously the word bi means two in Latin. You have two muscle bellies that actually make up your bicep. I'm going to show you my little guns here for a second. And so this muscle right here comes all the way up and attaches inside the front of your shoulder here. It literally goes up into what we call the labrum. And that labrum is the ligament tissue. It's kind of ligamentous in nature. It kind of holds that ball in place. Well, that long head of that bicep attaches up in there, and when you tear that, a lot of times you can get a labral tear in there also. But what happens is that tears off and it literally sits down here, and you have this bulbous bunch of muscle belly. And unfortunately, if you leave that long enough, which we're talking like less than 6 weeks, if you haven't gone in there and you're starting to work on it, the surgeon says, you got 6 weeks or less to pull that tendon back up there and then reattach it. And they won't reattach it to the labrum. They'll reattach it here to the front of the bone here of your humerus within what we call, there's a groove here. It's called the bicipital groove, where that tendon actually, there's literally a groove within the bone. As we grow and as we're pulling, as we are little kids and we're pulling, pushing and pulling, that groove gets deeper and deeper because that tendon gets longer, and it literally, in that, but when your bones, you're young, it's soft, your bone is more malleable, and that tendon actually builds a groove in there through friction, through our activities, and as we grow, through tension and torque and through gravity. And so you can get a nice thick groove in there, and so that's where that develops from. But needless to say, going back to that actual tendon there, that supraspinatus muscle, and when that pulls off, you really have a short period of time. And so that's the reason why when someone has a shoulder surgery and they go and ask someone else, hey, how'd you do with your shoulder surgery? And they're like, oh yeah, I had a rotator cuff tear. They didn't tell you which tears, how many tears, or is it all 4 muscles? Is it just one muscle? Did they have the labrum tear with it? So you can never compare 2 people the same with the same injury. On top of, were they born with the abnormality of the acromion? Were they born with the head of the humerus that was higher up, and that the space within that tendon is smaller to begin with, so that kind of predisposes them to the problem? So there's lots of reasons why you can't compare. It's never apples to apples. And that's the reason why some surgeons get kind of bashed. They're like, well, sometimes, unfortunately, there's only so much they can do, whether you're born with some abnormalities, or the tendon was ripped off for so long, or you had multiple muscle tendons. Maybe you had the supra and the infraspinatus tendons. They both come over and they both can tear. Most times than not, it's just a supraspinatus, but if you have a traumatic injury, then you can tear both of those, and that's going to make things a lot more complicated in there. And so I wish I could give everybody, a straight cookie cut answer like, oh yeah, definitely you have the same shoulder injury and you get the same surgery by this doctor, whoever, Mr. or Mrs. So-and-so, and you're going to come out with the same outcome as someone else. Not necessarily. And that's something we can definitely talk about in later episodes. It's really hard in the research, what we call inter versus intra reliability when it comes to therapy. If I do all your therapy versus if I do your evaluation and you go to someone else for some of the other therapy, and then you come back and you go back and forth, it makes it very hard to make a research because, my techniques or my skills of many years as I've done this, and a lot of courses I've gone through after going out of school, kind of gives you a little leg up versus someone that might not have done that, even though you're showing them the same techniques. There's a craft, you have your muse and art, where there's a craft and therapy a little bit when it comes to, making sure they're doing the exercise correct, making sure they should progress it when they should or when they shouldn't. So sometimes it is the therapist and how good they are. Do they do just shoulders? Have they done a lot of shoulders? Where they talk about 10,000 hours to become an expert in anything? Well, that could give you the same idea with, a therapist with shoulder, or, so I can tell you I got probably double that in hours when it comes to shoulders, and I've gone to a bunch of different seminars over the years. So needless to say, what I've told you in my recordings as well as my lives is exactly what the research is telling you. Whether it's a meta-analysis of almost what I think it was 3,600 participants, which is massive, or one of the most recent data on it, it really tells you the same thing. You want to rest it, you want to ice it, you want to do the anti-inflammatory medication for a good 72 which is 3 days, get that inflammatory process to calm down, then start the range of motion exercises. So, all that to say, yes, I'm not diagnosing anybody with anything. Let me always throw that disclaimer out there. You always want to go to your doctor. I'm not your licensed provider here doing telehealth. But, the information I give you is backed by research. It's not just popped out of my head. It's not from stealing from 10 other people either. So it's a good idea when you look at people's different podcasts and you look at people's different recordings that it's not just some pretty face, or that it's not some guy or girl at the gym that is looked at one of a therapist like me and stole the information, and they're not anything. So you always go to the source. And if you have any questions, you can always DM me down below. I'm going to try and do these recordings, these specific research recordings. I'm going to try and do a couple times a week. I'm going to go out and I'm probably going to go out and do a walk later this afternoon. And hopefully you guys will meet me out for that. And maybe I'll tell you a couple good horror stories. I think I got one on the top of my head. And then I think what I'm going to do, my next recording, I think I'm going to go back to the spine, go back to the neck, because I'm doing neck and shoulder. I've been doing that over the last, 4 or 5 videos. I'm going to go back to the neck, and I'm going to go a little bit deeper into disc issues, why they get better and why they get worse, why don't some ever get better. And so I want you guys to take a look out for that. I'll probably try and do that. What's today's Monday? I'll try and get that out probably Wednesday. But anyways, so if you guys have any questions, so I thank you guys all for coming. And like I said, 3 things to look out for when it comes to the shoulder. You can expect it's one of the 3 things: osteoarthritis, impingement, or some sort of tendonitis of one of those 4 main rotator cuffs. Specifically, I can give you probably almost 100% of the time it's probably the supraspinatus tendon. And if you let it irritate long enough for weeks and weeks and weeks, you might also have the infraspinatus that's also inflamed with it too. Then you're dealing with anytime you double your problem, you have 2 muscle groups and tendons that are inflamed, you can almost double the expectation of how long it's going to take to recover from it. So if I talk about it takes 2 or 3 weeks to recover from just a supraspinatus tendonitis, you can expect it's probably going to take the solid 4 to 6 weeks that I've talked about in my other recordings that it's probably going to take if you do the things that we talk about to get your symptoms to calm down. So don't beat yourself up that it's going to take a while. And if you've had problems in the past with the shoulder before, expect that it might take a little bit longer too, because there's scar tissue that can go in there. Scar tissue lays down huge. And if you have a diagnosis of keloid scarring, which is kind of a fancy word for someone who's kind of has a genetic disposition to excessive scarring, then you're dealing with issues on top of that too. You had a trauma in the past, you might have some scar tissue in there kind of muddying up that space, that subacromial space. So it's a lot of things that can go on. That's why sometimes the doctor wants, can't find it on an MRI, X-ray is clear. Let me just go in there and do exploratory and see if I can see, because the MRI isn't really clearly giving me an idea what the heck's going on. So hopefully you guys, give yourselves a break when it comes to that stuff. So I'm going to go ahead and leave you guys to that. And until next time, Scully and I always like to say, look up and keep smiling. See you next time, folks.